Hello. Now shifting the gears, I would be pretty fast given the circumstances. And at the onset, I would be thanking Team IDOS and everyone here to giving me the opportunity to speak on this podium. Now, I would be concentrating on the topic that is hit where it matters. So, we all have been speaking from the morning, PRK, collision cross-linking in, and we are just giving the surface a very good best fit sphere. But we do get patients which are having borderline or mild to moderate keratoconus, and these patients usually come with just differences in their glasses, which is again and again. So these patients, when we see the topography, it is very, very irregular. Their auto-ref readings and their subjective corrections have been very, very difficult. In this patient, we were having an inferior cone-shaped oval, which is for keratoconus. Now, I would be shifting just to the operative part, that is the patient's ablation profile. I would like to call everyone's attention on the ablation profile. And now, once the operation was done, the follow-up was having a significant haze, which patient didn't complain of because he was having a very good vision, and on low-dose steroids, travelose and cyclosporine, at 1 year, the patient was having 6 part unaided. And I would like all of you to just focus on this sclerotic scatter here. So here, if we can concentrate, the ablation profile exactly had an haze, and this haze actually helped us in making flattening of the cornea. And my today's point here is that surgical strike, we have to be flattening the steeper areas and elevating the flat areas. So
but if you go back to your case, if you do the differential mitomycin thing, you will avoid that crescent shaped scarring, because what happens is your cornea is an inferiorly decentered cone. So what is you have burned to make the cornea more regular in shape. It has burned close to 70 to 75 microns on the top.
Yes.
Because more the decentration it is, the more the burn on the opposite side.
Yes.
So what happens is, in these cases, if you next time you do, if you use a differential mitomycin in that zone, for at least you have to use it for close to a minute there, then that scarring will reduce and you will get the same result without an aesthetically poor scar.
Yes. So there's a significant difference if we can see from the scans that the patient's central 5 mm zone, the patient's topography was very fine, and patient's vision actually improved from 6-12 parts to 6.
How old is this patient?
22 years old.
No. How old is the ablation?
1 year.
So one challenge you'll have is, as it keeps increasing, that scar will become more stronger. So you will start seeing a huge amount of myopic shift suddenly, or the cornea can get them flatter. So that is one thing. So that's why keep him on this travelose or this cyclosporin for at least close to a year, because that scar, my worry is all lymphatic rust, because that will work, because the scar looks insignificant now, but as the patient goes older, that scar becomes more stronger.
So that's what my point for presenting this case was, that though we are using collision cross-linking and we are worried about the haze, but in my case, I just wanted to discuss the same point. This is the most important point from my side, that we are very worried about doing the lasers and exactly on the area of most thinnest part. But if by measuring the Contura platform, which I have used in the Wavelight, if we are stimulating and putting the direct PRK on the same spot, we are getting a significant haze, but it's not at the center of the pupil, but it's at the apex of the keratoconus. And because of that, there's a flattening of the most eminent part, and because of which there's a flattening and best fit sphere increases. I have done a couple of 8 to 10 patients, and everyone I'm noticing the same. Their unaided vision has improved drastically, and most of them are very stable. So the question I meant to ask was whether we should start our criteria more deliberately into the moderate to severe keratoconus and just give very minimal burn so that they may produce haze which will give us a flattening thing, or it should
Last
not?
12 years, we do around close to 1,500 cross-linkings a year. And I have never done only cross-linking. I've done everything is a combined one because the mindset of lasers on keratoconus is an outdated one. When you do it is called a control scarring, you're creating a balanced scarring which is away, which is giving you a combined effect of a cross-linking on that area. So what you're doing is right. Only thing is that peripheral scarring, try differential mitomycin, you will reduce it, and keep them, when you get more scar, keep them on long-term trehalose, omega-3 resveratrol kind of a thing so that they balance it, and you'll see much, and completely boldly try to offer combined procedure as the way to go. Cross-linking alone doesn't work at all because it's not improving anything to do with the quality of vision.
Thinnest Pachy or highest Kmax which you will take?
See, thinnest Pachy was a question once, but I think Shruti can give you, we have a calculator. I have done it at close to 290 microns. Not that I advise it, but I have done it. Farhad Hafizi has done it 240. That's a calculator which tells you, add it, it will tell you how much time you do, and I think that calculator can be shared by Natasha also. Use this, it will be very good. Don't worry about thinnest Pachy now because we have the thin calculator. If it's very thin Pachy, change it to 0.2% riboflavin. The calculator will tell you if I'm using 0.2% riboflavin, how much time I should use if you're using 90 milliwatts. A cycloplegia doesn't matter. And I told you about the haze thing. And PTK is the best way to do. Manual scraping induces changes on your keratocytes. There could be more chances of it. Try not to use alcohol at all in this because keratoconic keratocytes are very metabolically active. Alcohol will trigger more challenges for you, cause more haze.
And accelerated collagen cross-linking or the
9 milliwatts or 18 milliwatts is the best thing to do, but titrate it to the pachymetry use, which the calculator we can use it, or post lunch Natasha will tell you how to use the calculator. We have designed it, we have published it. It is given free, anybody can use it.
So we
same.
So thank you, Saurabh. We conclude this. I hand over to Sumit. So just an announcement, we'll have felicitation of our speakers and revealing of our journal. The IDOS journal is very different this time, so just 10 minutes we'll take. Then we'll start with lunch, and after lunch, half an hour lunch break, and we are back for the next session. Sumit, over to you.
We have been having an amazing session, thrilling. Even as a retina surgeon, I'm thinking to start my own refractive surgery practice. So, on a more serious note, before we start the felicitation, this month we lost one of our most cherished, most favorite ophthalmologist, Dr. Vijay Bhaisare sir. So it is my request to everyone to please stand up and observe a moment of silence. Sir was a beacon, and he was a friendly face, a senior ophthalmologist, and we lost him. So let's take a minute.
Thank you.
I would now like to